Hi everyone, and welcome to this MUPPITS revision lecture. So this one's going to be on development, mental health and behaviour. And it's going to be a bit of an overview, mainly focusing on the R1 conditions, but definitely a little bit of information about the R2 conditions, and then just a very brief summary. There's only one R3 condition for this particular topic. This topic probably doesn't come up a whole heap in the exam, I'd say, and there is definitely, or at least in our 2024 exam, there's definitely some overlap with psych and GP as well. So I'll leave some of those topics for our psych friends because I don't want to steal their thunder, but I will discuss them a little bit. As always, my email is on this particular slide, and you can always get in contact with either myself or the Muppets team generally through our social media. So please do feel free to reach out. But let's get started. Let's launch into it. So here's our contents divided into R1, R2, and R3. With R2 and R3 mainly being a little bit more buzzword focused, particularly the R3 condition for this particular topic. So looking first of all at autism spectrum disorder, ASD. So I'm going to cover etiology and a bit of the epi, clinical presentation, how it's diagnosed, bit of management and prognosis as well. So it's a neurodevelopmental disorder which doesn't have a well-known etiology. And it usually manifests at about 36 months, so 3 years old, because this is when the social demands of the child begin to exceed their capacity. Although, and research has shown this might be particularly in females as well, but it might manifest later in life if the child learns strategies to mask different symptoms or try and develop different social strategies to hide particular symptoms. So it affects about 4% of Australian children aged 5 to 14 years with a male predominance of 3 to 1. And I guess the clinical features can be grouped into 4 sort of areas: communication, activities, behaviour, and social interaction as well. So with communication, and different symptoms can also depend on the degree of ASD. But these are some of the symptoms that may be present, but there are definitely difficulties in each of these 4 areas that would be diagnostic of ASD. So echolalia is when there's stereotyped or repetitive speech. Children with ASD may also experience difficulties in non-verbal behaviours, such as eye contact, gestures, and posture as well. In terms of activities, these children usually have adherence to routines, don't like a whole lot of change as well in their routines, and can become quite upset if there is change. In terms of their behavior, again, there's quite ritualized patterns, so repeated phrases or actions. And they might be either overly sensitive or undersensitive to different sensory input. So, for example, loud noise they might not like, or potentially they have a very high pain threshold, so they might not respond to pain as much as people without ASD. And in terms of social interaction, we see difficulties in social emotional reciprocity. So this might be an absence of shared play. So as a child, they might prefer to engage in their own play, and also use of toys for purposes differently to how they're intended. So a prime example of this might be with a toy car. They might be more interested in spinning the wheels instead of actually I guess, moving the car as a whole and playing with it as a car. They might also have a little bit of difficulty with developing and maintaining relationships as well. So I won't go through this because I've sort of touched on all of these areas, but here is the DSM-5 criteria, and also this will probably be covered in the psych lectures. But with criteria A, that's just speaking about the social emotional reciprocity, nonverbal communicative behaviors and relationships, whereas type 3 is about those repetitive patterns and behaviors. And type C, D, and E is that these symptoms must be obvious early in development, that they cause difficulties in social, occupational, and other functioning, and it's not better explained by another condition. In terms of a clinical assessment for these children, um, I guess the diagnosis, first of all, comes in two parts. So, first of all, there's an assessment of function, and then there's also a medical evaluation as well. The assessment of function might be done by an allied health practitioner, somebody like an OT, potentially a child psychologist, and it's often looking at characteristics and strengths and skills in the child's activities of daily living. Often involves collateral history from the parents or caregiver. And the medical evaluation is done by a GP, pediatrician, or psychiatrist generally, looking for underlying rarer causes of ASD. So if there's a medical explanation. And ASD can be diagnosed as early as 12 months, but often occurs greater than 2 years. In terms of a neurodevelopmental history, you might want to have a look at things like milestones. So, when did the child meet their different developmental milestones? How do they play? And also, I guess observing them play is really important as well. And that forms part of a comprehensive assessment. Assessing their behavior, how do they deal with changes, transitions, etc. If they're at school or preschool, how they interact with other children and teachers, what are they like academically, how their skills and independence, what are their interests like, and how does this differ to their peers, and do they have any coexisting neurodevelopmental conditions as well. Some early signs that parents may raise concern with should be monitored because these can be early signs of ASD. So pointing, they might not look when you point out objects. They might not use eye contact. They may not respond to their name when they should. They might not imitate behaviors, which is what children learn to do at a young age. They might watch their parents say cooking in the kitchen and imitate mixing, for example. They might not babble or engage in social communication, pretend play. They might have unusual speech, like the echolalia we were speaking about before, and also looking at their sensory interests. And as we said, diagnosis usually involves referral to a pediatrician or child psychologist or psychiatrist, and it usually involves collateral history as well. And some children, depending on the setting, and obviously rural versus metro as well, might need some multidisciplinary involvement for diagnosis. In terms of management for the condition, looking at a biopsychosocial framework, which is a good way always to look at PEDS. Biological, involving that MDT is going to be really important. And early intervention as well has very strong research in ASD. And also there's NDIS funding for early intervention. So the earlier this paperwork and application is done, the more financial assistance a child and their family can have to access some of these services, like pediatrician, speech pathologist. OTs can help with things like routine and social skills. A social worker and psychologists might need to be involved as well. For example, for early behavior therapy. And then in terms of the social environment, educating family, and providing family support and counseling, and NDIS, as I said. Looking at comorbidities, as sort of mentioned before, there are lots of common comorbidities, for example, intellectual disability, learning disorders, Anxiety and depression. ADHD is really commonly comorbid, and ARFID as well, so that restricted eating patterns. And some medical comorbidities like epilepsy is quite common in children with ASD. In terms of the course, older children and adolescents often learn to mask symptoms when they're in social situations, and this can induce stress and anxiety. So it's important to monitor that and I guess provide children with psychological support for this because it can be quite distressing for them. And as mentioned before, early intervention is really critical to help build key skills in communication, emotion regulation, also social interaction as well. Moving on to ADHD now. So again, it has an unknown etiology, but it is known that dopamine and noradrenaline are involved. So there, in children with ADHD, there's an increase in dopamine transporter density, meaning that there's increased dopamine uptake at the synapses. It's occurs in about 5% of Australian children, again with males having the condition more than females. And particular groups are at high risk. So there is sort of a strong family history type link, premature children, and children with other neurodevelopmental disorders. Again, looking at the domains impacted, there's usually three or two key domains plus or minus overactivity. So in terms of inattention, children often have difficulty sustaining concentration on a task. They might forget instructions, so they might hear them and then not be able to follow them. And often they move quite quickly from one task to another without actually completing the task that they originally set out to do. These children can be quite impulsive as well, so act without thinking. They might talk over the top of others without intending to do so. They might lose control over their emotions easily and be quite accident prone. So in the classroom, these children, if their classmates and teacher don't understand, they may end up getting in quite a bit of trouble at school, which can also cause further problems for these kids. They may have overactivity involved, but this is usually seen more so in boys and girls, where they have that constant fidgeting and restlessness, but it's not a key feature. Um, Again, we've got the DSM-5 criteria, and some really good uh, mnemonics are call for Fred for the inattention, and then for the hyperactivity, impulsivity, run fast. And I won't go through these symptoms because they're on the screen, but you need more than 6 symptoms for more than 6 months, with these symptoms present prior to age 12, although it can be diagnosed after. You just need a collateral history, and the symptoms need to be present in two or more settings. So, whether that's social, occupational, or educational. So, you might, take a collateral history from a classroom teacher and then from a parent or caregiver or somebody who lives at home with the child as well. In terms of the diagnosis more formally, a formal psych interview is usually involved, and then a complete developmental history, a collateral history, and a medical history as well. And I think this is where a lot of downfall with ADHD diagnosis is at the moment, with the rise of these one-stop shops for diagnosis and medication prescription that are quite scarily quite available in the community at the moment without too much regulation. And they usually aren't nearly as thorough as they need to be. And they're sort of a bit more of a money-making service. So I guess that's a lot of concern amongst medical practitioners at the moment, is these pop-up ADHD clinics or rapid diagnosis without a lack of good follow-up as well. So these children being prescribed these medications, which, can still have some cardiac impact if not monitored correctly. So it's really important that the diagnosis is done properly and then that there's follow-up. That's a bit tangential of me. But looking at the developmental history, looking at milestones, do they have any comorbid intellectual or learning disabilities? What's the child's temperament like? Were these symptoms occurring before age 12? And did the child have any emotional life events like abuse or bullying, parental separation? Collateral history, as we spoke about, might involve looking at historical school reports. And then a medical history to rule out any medical issues that might mimic or aggravate symptoms. Having a look at a neurohistory because epilepsy is quite commonly comorbid. Perinatal history to see if there was history of prematurity or low birth weight. And nutrition and lifestyle as well, because these things can exacerbate ADHD symptoms. So it's really important to ensure that the child has good sleep and exercise, lower screen time as well. And are they engaging in any impulsive or high risk activities is important to gauge. In terms of a management and prognostic perspective, as always, I guess with psych and developmental conditions, psychoeducation and support are important for all children, behavioral treatments for most, and medications for some. So, psychoeducation to explain the diagnosis and treatment options is really important. Parent training programs can also be very useful as well, particularly if the parent doesn't need some assistance maybe with parenting skills. CBT, sorry, might be important, particularly if the child maybe has some comorbid anxiety or depression. And liaising with school is critical, or whatever educational system the child's in, to make reasonable adjustments to help the child learn. Because I think this is where a lot of schools can have downfalls if they don't properly understand the requirements for the particular child. So this might involve seating the child up the front, reducing lighting and noise and other distractions, providing them with movement breaks, having written instructions for them so that they're getting both written and verbal instructions, and maybe having a one-to-one teaching assistant if obviously that's very resource dependent. Then pharmacologically, so stimulants are first line, things like methylphenidate, dexamphetamine. So this is your Ritalin, your Concerta. And slow release is preferred over immediate release because then you've got drug on board the entirety of the school day, for example. Some of the side effects might involve a decreased appetite and increased heart rate and BP. That's why a baseline ECG is really important for these kids. And a baseline blood pressure. They might get some insomnia, a bit of irritability. Second line are non-stimulant medications like clonidine, I'm going to butcher the pronunciation, but atomoxetine. These can cause nausea and LFT dysfunction, but stimulants are definitely first line. In terms of the prognosis, about a third to a half of children with ADHD will, I guess, sort of grow out of it. Childhood ADHD is associated with poorer educational, occupational, social, health-related outcomes. That's why it's really important to diagnose and ensure good treatment and follow-up. There's also a high risk of earlier substance use and accidental injury as well. Yeah, so as I said, early intervention is key. So moving on to this is our final R1 condition. So developmental delay or disability. So starting with a definition, it's a broad term. It refers to delay and disability involving any of the four developmental areas. So gross motor, fine motor, speech and language, or social and emotional. Whereas global developmental delay is when you have two or more of the above areas that have delay. And developmental delay becomes a disability when the condition is likely to impact the child's function across their lifespan. So it's not just that they are acquiring these skills later, but that the skills might not be to the same level as some of their peers, and that continues as they get older. Looking at our etiology, it's helpful to break it down into prenatal, perinatal, and postnatal. Um, so prenatally, we have genetic conditions, things like trisomy 21, Fragile X syndrome. Acquired might be infections, congenital infections, maternal substance use, alcohol, hypoxia when the child was in utero. Perinatally, hypoxia, so during the birthing process or infection. And then again, postnatally, we've got infection, trauma, and hypoxia as well. What I've got up on the screen is some of the key developmental domains. So I'm not saying that you memorize all of these key skills, but just having a general idea, even just of the course, what skills come after one another. And this is just a checklist that the Sydney Child Health Network recommends that practitioners give out to parents so that they can track their child's progress and come to their health provider if they're concerned about any of the domains. It's just a really nice, easy checklist to have a look at. So I would definitely take a look at that. And then that just helps you track a child. So, if for example, at 6 to 8 weeks, they haven't been able to smile at you, just monitoring that over time and making sure that the child's followed up to make sure they acquire all the key skills. In terms of the clinical evaluation, parents might bring their child into you because the child's not reaching their milestones. They might have been referred from a maternal child health nurse. Childhood educators might be concerned, or it might be routine follow-up, like the child was born prematurely, and so they're booked in to see the developmental pediatrician or developmental clinic, for example. Um, so I guess some of the red flags for each of the developmental domains. Um, if the child's not smiling by 10 weeks or babbling by 12 months, this might raise some concern. Um, for gross motor skills, not being able to sit unsupported by 12 months or walking by 18 months. If they don't show a hand preference by 12 months, and speech and language if by 18 months they don't know 2 to 6 words. And then some other red flags in development, and these are really key ones and make you really concerned. Developmental regression. So if the child acquires skills and then they lose these skills, that's very, very concerning. If they have a particularly big, so macrocephaly or a small head microcephaly, or a change in head circumference. So that's why every time you see a child, it's really, really critical to get not only just a height and weight and plot that on the WHO or the CDC chart, but also to measure that change in head circumference, because that is a key red flag. And if the child also has new focal neurological symptoms, that also rings alarm bells. In terms of diagnosis and investigations, GPs are really, really critical in this, and they can do a really good initial assessment with history and exam and assessing key developmental skills. And they often are really well placed. They've seen the child over time, so they can also identify regression, for example. Then they might refer the child to a pediatrician or allied health professional to do a detailed developmental assessment using standardized assessments as well. In terms of investigations, all children with developmental delay, usually pediatricians do like this if the GP's already done this, but I'm sure they'll also order these if a child comes to them without these having been done first. But audiology and vision assessments are critical because this might be the reason, for example, that a child isn't saying those 2 to 6 words by 18 months. It could simply be a hearing issue. A CGH array is used to detect chromosomal abnormalities. Fragile X testing is often quite standard these days as well and is Medicare funded. And a urine metabolic screen can be done rare conditions, but often quite treatable. So it's good to do. And then, depending on the history, you might do some other investigations. So, if you've got dietary concerns, you might run some standard bloods. If there's a motor component, you might be willing to look at TFTs or creatine kinase, a whole exome sequencing. And this is often ordered by a pediatrician if the child has a moderate to severe intellectual disability and congenital signs and symptoms. And I'll leave the list up there as well for you to have a look at for the others. And in terms of managing this child, uh, it really involves building a therapeutic relationship, a relationship based on trust with the parents, and in identifying the child's strengths as well, not forgetting about those strengths. So, in terms of the child and family, practical social supports, um, strategies to support the child, anticipating the long-term impact, um, and how this might affect the child, particularly over transition periods to school, etc. And then also not forgetting about the family and carers. Um, Early intervention is key, as you'll hear a lot in developmental peds. So, of referring for an MDT input, um, assisting family to access NDIS, and also tying the family into local support services that might be offered by the council, like daycare, playgroup, etc. Educating the family and making sure they're engaged in educational services is really key. And then also potentially encouraging parents to attend a behavior parenting program, encouraging the caregivers to access their own support, like a psychologist or social worker. And in the case of quite severe developmental disability or carer burnout, referring the family for respite services. Yeah, and I guess this is really important to help prevent carer burnout as well. And in the speaker notes, you'll find some other really key strategies to support a child that come from Queensland Health that are really, really good that I won't go through. Um, and here are some really good guidelines as well on following up children with developmental delay or disability um, that I won't go through, but I'll leave them up on the screen. Alrighty, we are getting through this well. So getting onto our sleep disorders. Um, I'll start with a little bit of a sleep history or overview, because I feel like we don't get a whole lot of sleep teaching in med school. And I've only come to learn about this really through my honours this year. But sleep problems in children can be medical or behavioural, and a lot more commonly are behavioural. So a good sleep history is quite sequential, like any other history. Um, you want to have a look at bedtime. So, does the child have a pre-bedtime routine? Um, Screen exposure, particularly these days, are really, really important to flesh out because this could be the reason that a child's having poor sleep. Does the child have particular circumstances required for them to sleep? Like, does the parent have to be present, for example? What's their sleeping environment like? You know, are they sharing a room with siblings? Are they sleeping in their parents' bedroom? What time are lights turned out? And what time does the child actually fall asleep? And in terms of during the night, does the child wake? How often is this? How frequent? When is this? What happens when the child awakes? You know, are they quite scared? Do they come into the parent or caregiver's room? What does the carer do when the child wakes up? You know, are they encouraging the child to go back to their own bed, or are they allowing them to climb into bed with them? And is there any signs of OSA? Because OSA is a very, very common condition in children. So, are they having any mouth breathing, gasping, really loud snoring? In severe cases, are they sleeping with their neck hyperextended to open up their airways? In the morning, what time is the child waking? Do they need to be prompted? Do they seem refreshed? During the day, are they really sleepy? Are they overactive? Do they have any naps? And generally, how long has this been going on for? Is the routine different on weekends or holidays? Does the child have any caffeine, particularly key in adolescents? Are they on any medications that might interfere with sleep? And do they have any medical comorbidities? So, talking about behavioral sleep disorders first, um, these include difficulties falling asleep, waking up during the night, waking up really early in the morning, or a combination of all three. So, just going through some examples, we've got a couple of behavioral insomnias. So, we have a sleep association type. So, this is where the child struggles to fall asleep without the parent being present. Um, and usually, this is managed by controlled comforting or camping out. So, gradually reducing, um, I guess, the parent's presence when the child's falling asleep. Um, and then the limit setting type is when the parents have trouble setting limits. So the child comes out of their room or protests, and the parent might struggle to get the child back to bed. Um, Anxiety related insomnia is really common where the child takes more than 30 minutes to fall asleep. And they might also require a parent to be present till they fall asleep. And a delayed sleep onset is really common in adolescents, and it affects, yeah, about 7%, where their circadian rhythm sort of shifts and they might be going to bed quite late, but then for school they have to get up quite early, so they're not getting enough sleep. They're not often quite sleepy during the day. In terms of some key management strategies for infants, ensuring that they don't have naps past 4 p.m. so they can sleep at night, and also gradually tapering nighttime feeds. Sleep hygiene is critical, so making sure that the child has a regular bedtime, keeping the bedroom dark and quiet for teenagers, trying to avoid caffeine or at least after 3 p.m. Ensuring that the child's waking up at a semi-regular time on both the weekends and the weekdays, and limiting screen time to at least more than an hour before bed. And then also for parents, educating them about having clear expectations about bedtime. So once they've gone to bed, they have to stay in their room, and having a consistent bedtime. And also positive reinforcement for the child as well is really key. Organic sleep disorders. So I've touched on some of them. I won't touch on OSA because that's covered by the RESP lecture. But if we look at parasomnias, for example, these are abnormal movements, emotions, or behaviors that cause quite significant distress to the parent, caregiver, or child. And usually a pediatric sleep referral might be made if the episodes are frequent, but there's no actual harm in this condition. Periodic limb movements, or PLMs, are brief involuntary twitching or kicking movements, which are most often in the lower limbs. Results in fragmented sleep and lots of arousals. Sometimes unknown etiology, but often low ferritin can cause this, or SSRI use. They can be picked up on a sleep study or polysomnography. And for management, not much can be done, but if low ferritin is a cause, you might consider supplemental iron. Bruxism is involuntary motor activity of the jaw during sleep, which is quite common, and only pathological if it's causing damage to the teeth. So dentists might prescribe a mouthpiece. And central sleep apnea is when there's decreased or absent effort to breathe during the night. But instead of obstructive sleep apnea, where this is functional, so it might be from tonsils or adenoids or adiposity, this is a reduced drive to breathe from signals from the brain. It's commonly idiopathic and actually very normal in young infants, but can also be associated with conditions like Prader-Willi, trisomy 21, and other neuromuscular conditions. So often a referral to a pediatric sleep physician is necessary. Okay, we're getting into some of the more psych conditions. So I'll be a bit more brief with these because these will also be covered by our lovely colleagues at SASOM. But first of all, just speaking generally about eating disorders. So if we look at the etiology, studies have shown that there's strong heritability in twins, um, and those with personality traits like perfectionism, low self-esteem, and inhibitory control can be more prone. And also this social media epidemic and thinness worshipping culture um, can also be implicated as well. In terms of epidemiology, about 22% of Australian children and adolescents have disordered eating patterns. And adolescent females are at the highest risk, and it actually, very sadly, has the highest mortality of any psychiatric illness. So about 2% adolescents, and that's why intervention is really, really key. We've got a whole bunch of biopsychosocial risk factors here, which I won't touch on, but we'll leave them up for you to have a look at. In terms of some of the diagnostic criteria, so I've put, I'm mainly going to touch on anorexia nervosa and bulimia nervosa. But I guess just highlighting some of the key differences between the two. So anorexia involves a restriction of energy intake, which most often, although there are subtypes now where the child or adolescent is in the healthy weight range, but most often they have a significantly low body weight. You can see the severity levels classified by BMI in the table there. And the child or adolescent often has a very intense fear of gaining weight. And they have a sort of a disturbed perception of their own body image. And there are different subtypes as well, like the restricting subtype, where they purely diet or fast, or the binge eating or purging type as well. So I guess the main difference between, say, the binge eating or purging type of anorexia and then bulimia is that often with bulimia, the child or adolescent often has a BMI within that normal range. But yes, I guess to look at bulimia, there's recurrent episodes of binge eating. So, eating lots of food in a small amount of time, more so than what most individuals would eat in a similar amount of time, and a lack of sense of control during that time is very important as well. And there's often compensatory behaviors like vomiting, use of laxatives, excessive exercise, etc., after these episodes of binge eating. In terms of the clinical assessments, this is general for eating disorders in particular. So, a screening tool that can be really useful is called SCOFF. So, the S stands for sick. So, do you make yourself uncomfortably sick because you feel uncomfortably full? The C is about control. Do you worry you've lost control about how much you eat? The O is for loss of more than 1 pound, or which is equivalent to about 6 kilograms in a 3-month period. And then F, do you believe yourself to be fat when others say you are thin? And then the other F is for, does food dominate your life? There are also some other questions in the speaker notes that are more specific to bulimia nervosa. In terms of history, developmental and temperament history are key. As we spoke about before, there are a lot of predisposing factors at play from people's development and their baseline temperament as well that can predispose them to eating disorders. A general psych history, looking at comorbid mental health conditions, which are very common, assessing the weight change and stability over time, how long this is over, why the young person thinks their weight has changed in this way. So getting their insight is really key, because I guess in anorexia nervosa, they don't see it as a problem necessarily. how they feel about their body image, breaking down their eating habits specifically, looking at binge eating episodes, purging behaviors. Do they have any physical symptoms of malnutrition as well, like lightheadedness, um, uh, palpitations, for example, headaches? And often because they're malnourished as well, there might be cognitive changes, difficulties with concentration and memory, for example. On exam, and some of these are for quite more severe anorexia nervosa, but you might notice that the young person is emaciated. They might have lanugo or that very fine, thick hair on their arms and legs. Russell sign is more specific to bulimia or the purging subtype of anorexia, where the young person has calluses on their knuckles from self-induced vomiting and some other signs noted there. Looking at postural BP and pulse is really important as well because some of these looking at vital signs is really important in deciding if a young person needs to attend hospital for their eating disorder. You might consider a thyroid exam because hypothyroidism, I guess, can be a mimic, and then doing a cardiovascular exam too. Investigations looking for arrhythmia or prolonged QT interval, which can happen with electrolyte derangement, standard baseline bloods, and a DEXA scan if the young person's been underweight or hasn't had a period for more than 6 months, and just every 2 years as well for follow-up. In terms of management, as I spoke about, some children and adolescents are going to need medical admission to manage their refeeding, particularly if they're at risk of refeeding syndrome, which is that sudden electrolyte disturbance that occurs if refeeding is done too quickly. So here are some of the symptoms and signs, the signs to look out for, and the criteria for admitting young people with an eating disorder. So that's why it's really key to look at vitals in particular if a young person presents to you. In terms of psychoeducation, I guess one of the key things is really explaining the diagnosis and making sure that the family and young person understand it and really trying to break down that stigma if you identify that as an issue. And family-based therapy is first line. But if this is just not practical in a particular family unit, individual therapy can be done, but family-based is definitely key. Nutritional and medical management involves helping the young person return to a healthy weight. And this so-called healthy weight is a weight that allows them to achieve endocrinological normality. So, for example, regaining regular periods and other endocrine hormonal systems. And the rate of refeeding, as we spoke about, you don't want to induce refeeding syndrome. So, as an outpatient, dietitian input's really key here. And then support for family and carers. So, through Eating Disorders Victoria can be a key resource. We'll quickly look at chronic fatigue syndrome now, which is a complex multi-system disorder where the young person experiences severe fatigue, cognitive dysfunction, sleep problems, autonomic dysfunction, and malaise after exercise. Etiology is unclear, although hypothesized causes might include a family history, infections like EBV, human herpes virus, parvovirus. It's more common in adolescents than younger children and more common in females than males. The diagnosis involves chronic fatigue lasting more than 6 months, which is investigated, but there's no clinical explanation for it. It's very persistent or it relapses. There was a definite onset. It's not the result of, say, a child being in high performance sport. It's not relieved by rest. And the child or young person has a much lower ability to carry out their ADLs. And there's 4 or more symptoms, including memory or concentration issues, And other symptoms like sore throat, lymphadenopathy, myalgia, joint pain, new headaches, their sleep's not refreshing, and post-exertional malaise that lasts more than 24 hours. Investigations, it's usually a clinical diagnosis, but as we spoke about, to rule out some of the other causes of fatigue, you might perform some of these bloods, things like FBE and iron studies to look for iron deficiency, thyroid function tests to look for a thyroid picture, CRP, ESR, looking for some sort of chronic inflammatory autoimmune conditions potentially. Celiac screening is key because untreated celiac disease can cause incredible fatigue, and the young person might not always have other symptoms, and then also just be guided by other symptoms as well. Management, so non-pharmacological management is key in chronic fatigue syndrome. So regularly reviewing symptoms and severity every 3 months is key because some of these young people can feel dismissed or like their condition isn't important, which can actually worsen outcomes. So really regularly tying them into seeing yourself or another healthcare provider is important. Um, Helping to plan or create an activity plan to promote involvement in ADLs, avoiding pain triggers like making sure the young person gets enough sleep, reducing stress and regular meals, um, trying to get them involved in exercise again. That might be a graduated return to exercise. As we said, good diet. Pain management might involve things like heat and cold packs, physio, massage, um, and managing comorbid mental health conditions as well. Pharmacological is not as common, but if the young person has significant insomnia, melatonin might be used as an adjunct, and tricyclic antidepressants like amitriptyline if they've got severe chronic pain. Um, this is a very broad, non-specific topic, but just speaking about um, adolescent mental health briefly. So I just thought I'd do a little touch on the epi. So about 15% of Australian adolescents 12 to 17 years have a mental illness. Um, and the rates of mental illness are higher among adolescents from a low SES background and an outer regional background as well. So it's really important that this inequity is addressed. About 10% of adolescents have ever engaged in deliberate self-harm. Um, and then 8% of adolescents have considered attempting suicide in the past 12 months. So this came from an Australian study. And you can see here that anxiety disorders and ADHD are the most common mental health conditions. And then I'm just going to touch on depression and anxiety. So in terms of major depression, the symptom domains involve a psychological or cognitive component, so issues with concentration and memory, feelings of guilt and worthlessness, fatigue, and plus or minus suicidal ideation. People can often be quite irritable, have and experience anhedonia or a lack of interest, have low mood, and experience boredom. And then biological symptoms may include sleep disturbance, weight or appetite change, and sexual dysfunction as well. And the diagnosis is more than 5 symptoms during a period that's greater than 2 weeks, and one of those symptoms must be anhedonia, so that disinterest, that lack of motivation, or a depressed mood. Looking specifically at adolescents, sleep and appetite disturbances are quite commonly reported. Suicidal ideation and attempts, and they often have quite high impairments in their functioning, so might have a lot of missed school, for example. Anxiety, so looking at risk factors, having a comorbid mental health condition, chronic illnesses like cystic fibrosis that affect daily functioning, if the young person has gender related concerns, if they've experienced significant trauma, if they've got a family history of any mental health condition, or they use substances. Symptoms might involve avoiding school and social events, frequent somatic complaints like stomach aches, um, that often resolve on the weekends, for example. Sudden emotional or angry outbursts. They might have trouble with sleep or appetite again, seeking reassurance, being preoccupied with their thoughts, and over planning and overthinking. Management involves, again, that biopsychosocial framework, but therapy is key here. So, CBT, or interpersonal therapy as well. And if the young person is to be started on medication, fluoxetine here is key. So starting low and going slow, and making sure that the young person is educated about side effects to avoid that withdrawal syndrome, and obviously letting them know about activation syndrome and safety netting for that increased self-harm or suicidality in the first couple of weeks is really, really important. And then here I've just got some questions, some screening questions to ask somebody who you were concerned about self-harm or suicide. And these you might identify from a head screen, or you might, this young person might come to you with these concerns as well. So with self-harm, I guess it's really key just to ask about what the adolescent does to self-harm and what they're seeking from it as well. And looking at previous hospitalizations, this just helps you assess their risk of, I guess, relapse or severity. How concerned are you? What access to methods of self-harm do they have? And lethality of this is really, really critical. How often do they do it? When did they last do it? And, are they engaging in help-seeking behaviors? Because you'll be less concerned about adolescents who are telling people that they're, going to a trusted person to tell them that they are self-harming, for example. And are there any hallucinations or delusions? Like, is there a psychosis going on, for example, as well? I've got a bunch of questions here to ask a bit more about suicide as well that I won't go through because there's quite a few questions there. This might just be a good resource to go back to. Management for these young people involves, first of all, identifying protective factors to help form a safety plan with this young person, and tying them into these social supports and protective factors that they identify. Making sure that the young person is adequately informed about mandatory reporting if they're at risk of harm to themselves or others. So making that clear to them before you start speaking to them. Really trying to involve a parent or caregiver where possible, with the consent of the young person. And obviously, if you've got immediate or serious concerns, arranging an immediate CAT assessment or referral to ED. Just touching quickly on this one R3 condition, which is school refusal. So it's a term that encompasses truancy, school refusal, and school phobia. So it's really important to look at this. I guess if we go quite psych focused and we look at that Bronfenbrenner micro macro system. So looking at the child themselves, who's at the center of this, and then their family and school, so their support systems around them. So does the child have, for example, learning difficulties or a psych disorder that means that they're not wanting to engage in school, or they're finding it difficult to engage in school, or medical disorders, which mean that their symptoms are also making it difficult to focus at school. Having a look at the family, is there poverty or homelessness? So does the child not have a secure place to live? Are they a victim of abuse? Is there family conflict going on? or parental mental health and addiction, lack of parental involvement. And then the school itself, is it a period of transition, like from primary school to high school? Is it happening around exams? Is that young person experiencing anxiety, for example? Is there bullying or friendship problems? Does that young person not feel a sense of connectedness to their school community? And are they bored at school or don't have adequate support for their learning needs? This might be manifested in frequent somatic complaints like stomach aches, headaches, um, and frequent requests to go home or for the teacher to call the family, for example. When the child's dropped off at school, there might be tantrums or clinging, lots of unexplained absences from school, classes that are missed, or long periods spent in sick bay. And in terms of managing this, a full assessment is key by a paediatrician or a child psychologist or psychiatrist to identify those precipitating factors. What's the root cause of this? And it should involve those three domains as well. Try to mitigate social factors where possible. So social work input might be necessary here. Treating the underlying or optimizing the underlying mental or physical illness to try and help that child re-engage in school. And planning for a graduated return to school, because the longer that the child spends away from school, the harder that it will be to return. So that comes to the end of our presentation today. I'd like to thank you all for bearing with me. I hope I didn't speak too quickly, but please, as always, do feel free to get in contact with us at MUPPITS, or I had my email at the start of the presentation as well. So you're more than welcome to reach out if you have any questions about this presentation or anything PEDS related as well. But best of luck for your upcoming exams and apexes as well. And I'm sure that you will all absolutely smash it. Thanks, guys.